there, everyone. It's really great to meet you all. I'm Katie Largent, and I'm a physician assistant at Vanderbilt University Medical Center with their stem cell transplant and cellular therapy department.
Hey, I'm Bagi Dolaria. I'm an assistant professor in Division of Cell Therapy and Transplant. I work very closely with Katie here, and thank you everyone for joining today.
So I'm really excited to be talking to you all about the acute and long-term cardiovascular complications associated with stem cell transplantation. Dr. Dolaria, do you mind if I go ahead and get started?
Yes, Katie, please take it over.
All righty. So first of all, I just want to let you all know that I have no disclosures. Our learning objectives for today include, by the completion of this lecture, ideally we'll have the learner be able to recognize common cardiovascular complications associated with conditioning chemotherapy, as well as radiation therapy given prior to hematopoietic stem cell transplantation. I'd like for you all to be able to recognize long-term cardiovascular complications that are prevalent in our patient population. And I do want to touch briefly upon screening and prevention strategies in our transplant recipients to really keep them as safe as possible and prevent cardiovascular disease as best as we can.
Cardio-oncology is the study of cardiology-associated diseases in our cancer patients. Why is cardio-oncology important? Cardiovascular disease is the #1 leading cause of death worldwide, and there are 17.9 million deaths annually associated with cardiovascular disease. This accounts for 32% of all deaths globally. Cancer is the second leading cause of death worldwide, with nearly 10 million deaths annually, which accounts for 16.7% of deaths globally. So when you think about this, as our patient population continues to age, the incidence of cancer and the incidence of cardiovascular disease continues to rise. And our adult cancer patients have up to an 18% increased incidence of cardiovascular disease. So it's really important to address cardiac disease in our patient population, pre-transplant, during transplant, and then the post-transplant setting. So the first thing we like to do in our patients is do a cardiovascular toxicity risk assessment. This is done prior to receiving chemotherapy and radiation for the stem cell transplantation. Why do we do such an intense workup before the patient gets chemo or radiation? And that's really to make any interventions pre-chemotherapy and pre-radiation to modifiable risk factors. So anything that we are able to modify and optimize prior to transplant, we will try to do so. And then we also determine the appropriate chemotherapy regimen based on comorbidities and current cardiorespiratory fitness status. So it's really well known that myeloablative chemotherapy regimens have a higher incidence of cardiovascular complications compared to their reduced intensity counterparts. So this pre-transplant cardiovascular toxicity risk assessment is truly how we determine what chemotherapy we give our patients and what we need to be watching for and looking out for. The goals of this assessment, as I mentioned previously, is to decrease the long-term cardiovascular complications from chemotherapy and radiation. And multiple studies have shown that if we address the cardiovascular risk factors of our patients pre-transplant, it'll decrease their length of hospital stay during transplantation. It'll decrease the overall cost of care to our patients, and it'll help prevent cardiac complications as able. So additional considerations before we start chemotherapy or radiation are our patients' underlying medical comorbidities. Overall, the incidence of short-term and long-term complications in patients with at least 2 cardiovascular risk factors, which we'll go over in the next slide, identified before transplantation, they were found to have in allogeneic stem cell transplant patients, a 7.5 incidence of short or long-term cardiac complications. And for our autologous stem cell transplantation patients, about 2.3% at 15 years of follow-up. Our recommendations would be to take a very thorough past medical history to identify any underlying risk factors. We recommend a clinical assessment and evaluation, and then any kind of medical optimization that we can do for our known medical comorbidities prior to transplantation is ideal. So I wanted to go over and touch upon medical comorbidities that we can have some factors that are modifiable and those that are non-modifiable. So our non-modifiable risk factors for cardiovascular disease include age, female sex, underlying chronic kidney disease, and of course our pre-existing cardiovascular disease such as coronary artery disease, heart failure, previous cardiotoxicity from our chemotherapy or radiation that our patients receive prior to coming to stem cell transplantation, and anyone with a depressed EF. Oops, sorry. Our modifiable risk factors include hypertension, diabetes, hyperlipidemia, obesity, smoking, sedentary lifestyle, and electrolyte abnormalities. So any of these modifiable risk factors that we can optimize prior to transplantation, we should. If we do have the time to do so, getting their blood pressure under control, having excellent control of their diabetes, having our patients on a statin. Obesity is a harder one. We don't really want our patients losing weight prior to transplantation and during transplantation. So that one we kind of put on the back burner. Obviously, we at our institution require our patients to have no smoking during transplantation and the months, hopefully the months leading up to transplantation. And of course, we encourage all of our patients post-transplant not to be smoking. We do encourage an active lifestyle in our patients, and we monitor their electrolytes almost daily. Other considerations before we give our transplant-related chemotherapy and radiation is previous cancer therapies that our patients have received. So based on previous studies, there are certain drugs that are high risk and low risk at causing cardiovascular disease in our patient population. So any patient who has had a cumulative doxorubicin equivalent of greater than 250 milligrams per meter squared, radiotherapy of greater than or equal to 35 grays, including radiation to the mediastinum or the heart, and or radiation of greater than 15 grays to the mediastinal area, and doxorubicin of greater than 100 milligrams per meter squares put our patients at a high risk of developing cardiovascular disease later down the road. Lower risk, but still a risk compared to other medications and drugs, are non-anthracycline regimens, radiation that's 15 to 35 grays in the mediastinal area, and a cumulative doxorubicin or equivalent of 100 to 250 milligrams per meter squared. So when patients come to us in the pre-transplant setting, we do recommend checking blood pressures prior to undergoing transplantation. We will get a baseline echocardiogram on our patients, a baseline EKG, and then labs to consider will certainly be a lipid panel, an A1C, which you can't necessarily trust if the patient's been getting a lot of blood transfusions. We have our cardiac biomarkers, so our troponins and our BNPs. Those are excellent baselines to have on some of our patients, especially our patients who have known cardiac disease and our patients like our cardiac amyloids, because these numbers are really sensitive. And if you're seeing them trend up during the like peri-engraftment period, you'll know that trouble might be on the way. So those are great markers to have available. And then otherwise, for all of our patients, we do a hematopoietic cell transplant comorbidity index score. And again, like I mentioned, medical optimization prior to transplant is really our goal here. Beta blockers and ACE inhibitors where appropriate. And if our patients are deemed high risk for severe cardiac complications, at our institution, we refer them to a cardio-oncologist prior to elective chemotherapy if we're able. And I encourage everyone to be able to do so if your institution has cardio-oncologists. They're a great resource and certainly utilize them as able. Otherwise, I did want to just make note of these drugs that chemotherapy agents that can cause cardiotoxicity. I wanted to kind of go through some of them, name some of them, so that way if you hear them or see on your patient's medical history that they've had these medications in the past, that should trigger a kind of a warning that, hey, maybe these patients are at higher risk of cardiovascular disease during the transplant process and afterwards. So anthracyclines are our biggest chemotherapy agents that cause cardiac toxicity. So these would be drugs that include doxorubicin, idarubicin, daunorubicin. And again, a lot of these medications are drugs that patients have gotten prior to stem cell transplantation, not the drugs that we give them to condition them. So this is used for treatment of lymphomas and leukemias. These drugs that are starred are the ones that have the highest incidence of cardiac toxicities. So anthracycline-induced cardiotoxicity, acute cardiac toxicity occurs in approximately less than 1% of this patient population. However, as time goes on, the incidence of cardiotoxicity related to these drugs does increase. So about 1.6 to 2.1% of the patient population will develop cardiac toxicity related to these anthracyclines they've given. It's more common to have late onset, so after a year of administration, the risk of getting cardiovascular disease or toxicities increases to about 1.6 to 5%. And these late effects can show up actually up to 10 or 20 years after being administered this chemotherapy agent. So we'll talk about this later on in the presentation, but screening your patients for cardiovascular disease is a very important way to identify it early and to treat these patients. And for our anthracyclines, these are very much so dose dependent. So those who receive a low dose of anthracycline are much less likely to get cardiotoxicities compared to those who have high dose. So high dose incidence of cardiotoxicity peaks at 48% of patients who receive it, and low dose is up to 5%. The main cardiac complications associated with anthracycline use include left ventricle dysfunction or cardiomyopathy, congestive heart failure, EKG changes such as QTc prolongation, and arrhythmias. Next, I'd like to talk about our alkylating agents. So these are ones that we more commonly use during our conditioning therapy. So this includes our drugs like cyclophosphamide, melphalan, busulfan, and then as well as bendamustine, carmustine, thiotepin, ifosfamide. So these drugs treat our lymphomas, leukemias, multiple myelomas, amyloids, germ cell tumors, as well as our conditioning for stem cell transplants and cellular therapy. The prevalence of cardiac complications with these agents, melphalan is our most arrhythmogenic agent. It increases the risk of atrial fibrillation to 11% in all patients who receive this. Our cyclophosphamide, at high dose, you have an incidence up to 26% of myopericarditis. This is typically early onset and usually occurs within the first 7 days of administration. And cyclophosphamide is one of our drugs that longitudinally or more down the road will see the cardiomyopathy side effects. So up to 28% of our patients who receive cyclophosphamide will develop left ventricular dysfunction down the road. Otherwise, our alkylating agents cause heart failure, cardiomyopathy, arrhythmias. So like I mentioned, predominantly AFib, though atrial flutter and SVT are common. They can cause pericardial effusions, mild pericarditis, endocardial fibrosis. You can have cardiac tamponade, although that's much rarer. EKG abnormalities such as left bundle branch blocks and QTc prolongations. You can also have myocardial ischemia and arteriovascular disease. And our most common induced cardiotoxicities would be our cardiomyopathies, heart failure, and arrhythmias from our alkylating agents. I'd like to touch briefly on our TKIs, our tyrosine kinase inhibitors. So those would be our imatinibs, dasatinibs, bosutinib drugs. Those are commonly used to treat BCR-ABL positive leukemia, and occasionally they're used to treat myelodysplastic syndromes and myeloproliferative disorders, depending on cytogenetics and molecular mutations. These medications commonly cause left ventricular dysfunction, so our cardiomyopathies again, our heart failures, and these commonly cause QTc prolongation. So in our patients, we are often checking EKGs and adjusting doses when we are giving these. Other less common side effects of TKIs include coronary microvascular dysfunction, arteriovascular disease, as well as arrhythmias. Other notable cardiotoxic chemotherapies that I wanted to touch upon that we often use in our conditioning chemotherapy regimens include etoposide. The common cardiac complication of that is an acute MI. Again, this is very rare and do not happen often, but I just kind of wanted to put it on your radar. Cytarabine, which is used for leukemias, lymphomas, and conditioning, can cause complications of pericarditis, heart failure, and bradycardia. Fludarabine, which is used for CLL, Hodgkin's lymphoma, as well as our conditioning chemotherapy, has an 8% risk of cardiac dysfunction and heart failure. Again, this is more likely in the long-term setting than acutely. And again, cardiac complications of fludarabine include CHF and bradycardia. And then when you combine fludarabine and melphalan, that increases our all-cause cardiovascular events up to 14%. And about 2.5 of these events are considered severe and will require hospitalization and acute management. I did want to put this chart in our discussion today. So this is these are the most common chemotherapies that we use for conditioning in our patient population. And these are their associated cardiotoxicities. So a lot of these we touch base upon. I just wanted to put this in a nice chart form for you all to be able to reference as needed in the future. Additionally, I wanted to touch base on radiation therapy-induced cardiotoxicity. So this is, we commonly use TBI in our aplastic anemia patients, our sickle cell disease patients, so I did want to include this on here. Risk factors for radiation associated heart damage or cardiotoxicity are dose dependent, so doses greater than 30 to 35 gray, doses per fraction of greater than 2 gray, a large volume of the heart area or mediastinal area that is irradiated, the younger age at first exposure. So I personally treat adult stem cell transplant patients, but our young pediatric patients who have radiation therapy do develop cardiotoxicities at much earlier ages in life, like can get them in their 30s. Longer time since exposure. So with radiation therapy, any type of cardiotoxicities we're going to see are usually years and years down the road. If you have associated use of cytotoxic chemotherapy, that also increases your risk of radiation-associated cardiotoxicity. Endocrine therapies that might be used increase your risk of cardiotoxicity with the use of radiation. And then, of course, your beautiful coexisting medical comorbidities. So anyone with hypertension, diabetes, hyperlipidemia, obesity, smoking also increases your risks of cardiotoxicity if you get radiation. So the prevalence of radiation induced cardiotoxicity, it occurs in about 40% of our patients, and this is due to microvascular damage. Pericardial disease occurs in about 90% of all patients exposed to significant mediastinal radiation. About 50 to 63% of patients treated with thoracic radiation therapy will develop these myocardial interstitial fibrotic-like areas in tissue. And again, it's usually that 5 to 10 years after radiation therapy, we see the incidence of cardiac disease that increases. And up to 10 to 30% of patients, and again, even our pediatric patients can have cardiac disease. So early screening and prevention and treatment of these diseases and identification is really important here. So there's a big old list here of the cardiac complications one can get from radiation. The most common, because it is, especially the ones that are getting the radiation to the chest, the most commonly you'll get your acute pericarditis or your myopericarditis, and that's just inflammation. The acute pericarditis is, the inflammation of the lining around the heart, and the myopericarditis is inflammation of the myocardium itself. And again, that's really just because of direct damage and hit to the cells in the heart tissue and cavity. You can also get valvular stenosis, which is something that will develop over time. We've mentioned that cardiac fibrosis. You can have coronary artery disease develop, especially in the left anterior descending and the right coronary arteries, because those are on the front or anterior side of the heart. You can get conduction abnormalities, pericardial effusions, hypertension, congestive heart failure, and restrictive cardiomyopathies from radiation therapy. I wanted to touch base on the most common cardiac complications, just kind of in general throughout the first 100 days after transplant. So our most common cardiac complication in hematopoietic stem cell transplantation is cardiac arrhythmias. And that's really our atrial fibrillation and our atrial flutter. So the total incidence is upwards of 27% in our patient population. Otherwise, we certainly will see congestive heart failure, pericardial effusions with or without tamponade, thromboembolic complications, pericarditis, myopericarditis, and very rarely myocardial infarctions. So as I mentioned, atrial fibrillation and atrial flutter are our most common cardiac complications during hematopoietic stem cell transplantation. And there are a lot of risk factors that are associated with this, including older age, active infections, a baseline dilated left atrium greater than 3.5 centimeters. And just of note, this dilated left atrium, one study showed that up to 78% incidence of developing AFib or A-flutter if the left atrium is greater than 3.5 centimeters in diameter. If you have underlying AV nodal block, including PACs on baseline EKG, you will be at increased risk of atrial fibrillation. If you have a history of atrial fibrillation or atrial flutter, you'll be at increased risk. If you have a history of hypertension, heart failure, coronary artery disease, and of course, our cardiac amyloids are at high risk of developing these arrhythmias. Our goal is to prevent atrial fibrillation and atrial flutter during transplantation. We do so by weight and fluid management. So in our patients who have a weight gain greater than or equal to 7% within their first week of transplantation, that increases their risk significantly for developing atrial fibrillation or atrial flutter. We do want to ensure good nutritional intake. We want to optimize our patients' electrolytes. In particular, our potassium and magnesium electrolytes are highly cardiosensitive and can, if they're abnormal, trigger atrial fibrillation. And then, of course, our patients with pre-existing history, you want to be very careful about discontinuing any rate or rhythm controlling agents. Otherwise, during the first 100 days, congestive heart failure exacerbations can occur. Congestive heart failure exacerbations actually are more commonly due to previous underlying diagnosis of heart failure versus new onset of heart failure or cardiomyopathy during the first 100 days. Developing a new CHF or cardiomyopathy really is a disease process that occurs in the long-term setting. Again, for CHF, prevention is key. We want to manage volume status closely, and we want to monitor input and output. And of course, we want to adjust our diuretics cautiously. So you really just want to be sure to assess your patient's volume status daily is my biggest take home in regards to heart failure. Otherwise, I wanted to touch base upon some less common cardiac complications during the first 100 days after transplant. So we will see pericardial effusions occur in our patients. They're more rare than anything, but when they do occur, it's typically secondary to delayed engraftment, thrombotic microangiopathy, or early relapse. It most notably occurs in patients who receive high-dose cyclophosphamide, so that's anyone that's considered to have gotten a dose greater than 170 milligrams per meter squared. The onset is typically within 10 days of drug administration. So we'll see this as early as day +1, day +2, after chemotherapy has started, or sorry, day +1, day +2 after transplantation, because they started these drugs, day -7 of the transplant process. The mechanism of action that's proposed for these pericardial effusions that do occur are secondary to capillary fibrin microthrombi in the myocytes and the interstitium. Otherwise, there are certainly thromboembolic cardiovascular complications that I do briefly want to touch upon. These are much less common compared to atrial fibrillation, heart failure exacerbation, and pericardial effusions. They fall into four main categories, and those categories would be the venous thrombus events, catheter-induced thrombosis, TMA, so our transplant-associated thrombotic microangiopathy, and our veno-occlusive diseases. Ischemic cerebrovascular accidents are very rare during transplantation. The incidence is about 0.3 to 5.3%. These are not well studied, and overall, it's much more common to develop a cerebrovascular accident after day 100 than it is during the first 100 days of transplant. Common risk factors include high-risk hematologic diseases that put you at a higher risk of developing thrombosis, prior venothromboembolism. Anyone with grade 3 or 4 acute GVHD is at higher risk. Those who have had TMA, those who have had multiple transplants, so be worried in your patients who are undergoing second allogeneic stem cell transplants. And then anyone with underlying diabetes, high blood pressure, or hyperlipidemia are at risk of developing cerebrovascular accidents. Another less common cardiac complication during the first 100 days of transplantation includes pericarditis and myopericarditis. The incidence is near 3%. Risk factors for developing this include our conditioning chemotherapy regimen. So anyone who's had anthracyclines, especially previously, as well as total body irradiation, are at higher risk. Anyone who has an active infection, anyone with acute GVHD, or someone with a history of pericarditis previously. And what I thought was most interesting is the median time to onset is bimodal, in that it is near 7 days post-transplantation, or it will occur much in the distant future after day plus 100. And then I just briefly wanted to put myocardial infarction on here. So myocardial infarction during the first 100 days of transplant is very rare. It's not well studied or well documented. It is suspected to be demand mediated. So this is really likely due to stress from infection or febrile illnesses, as well as stresses from regimen-related toxicities in our frail patient population. Otherwise, long-term cardiovascular toxicities is something I'd like to touch upon because it is something that will affect our patients longitudinally through the rest of their lives. So compared to the general population, our patients have much higher incidence of cardiovascular disease and will develop cardiovascular disease at a much younger age. So our patients will have a 7 to 15.9% increased risk of cardiovascular risk factors at a younger age. This will include hypertension. So hypertension is prevalent in 43% of our patients compared to the general population at 34.6%. Diabetes is increased at 18.7% compared to 8.5% in the general population. And hyperlipidemia is at 43% in our patient population compared to 40% in the general population. Late death due to cardiovascular complications is 2.3 to 4% increased risk in our patient population. And what I found most interesting throughout all my research over time, it's actually our female patients who undergo autologous stem cell transplants that have the highest risk of late death due to cardiovascular complications. So this begs the question of why is the long-term risk of cardiovascular disease so high in our transplant recipients? This is because cardiotoxic effects of chemotherapy and radiation received prior to stem cell transplant. And then, of course, that combined with our chemotherapy and conditioning regimens that we use really causes indirect injury and direct injury to our cardiac structure. We also have to take into account our pre-existing cardiovascular disease and risk factors. And then this is our big one here, our post-transplant lifestyle. So our post-transplant lifestyle does contribute significantly to developing cardiovascular disease in the future. And that's because a lot of our patients have decreased activity. Their diet may not be poor or may be very poor due to taste buds altered and taste mechanics, and just really not wanting to eat or drink anything that's particularly healthy. You know, during the first 100 days, we often say whatever you need to eat or drink to get calories in is fine. But after that first 100 days, once the patient is getting further and further out from transplantation, it's really good to encourage a well-balanced diet. And then often our patients will gain weight in the long-term setting, and that's due to decreased activity, poor diet, and then of course, if anyone develops GVHD and is put on corticosteroids, there's a significant weight gain associated with that. So I just wanted to touch upon our most common cardiovascular toxicities in the long-term setting of our transplant recipients. So heart failure and cardiomyopathy are by far our most common long-term complication, cardiovascular toxicity from transplant. And it accounts for 68% of all long-term patient deaths. The overall incidence is about 11.7% in our patient population, and the median onset is 3 years after our hematopoietic stem cell transplantation. Our second most common long-term cardiovascular toxicity secondary to stem cell transplantation is coronary artery disease. And this occurs in this accounts for 32% of all long-term cardiovascular toxicities that are noted in our transplant patient population. Pericardial effusion can happen in the long-term setting, and that's commonly due to relapse disease or those with significant underlying chronic GVHD. So that's just always something to consider. And then less common, but certainly still prevalent, includes our cerebrovascular disease, our pericarditis, myocarditis, and vascular disease are more common in our patients compared to the general population. So what do we do to help care for our patients who have undergone stem cell transplantation and are at this higher risk of cardiovascular disease? Our biggest recommendations are to do routine screening in our post-transplant recipients. That includes annual screening for diabetes. You'll check initially at 3 months, 12 months, and yearly after transplant. We check our lipid panels pretty regularly in our patients, so you'll check at 3 months, 12 months, and yearly after transplant. You evaluate patients for blood pressure and hypertension at every single visit. On this, it says check at least yearly, but we all know that we're seeing our patients in the long-term setting much more frequently than once yearly. But after you get to that year mark, when you're maybe decreasing immunosuppression and seeing your patients less and less, you really do want to continue to check blood pressure. Obesity, obviously, we're going to check a weight of our patients at every visit, and when appropriate, certainly addressing that and giving lifestyle modifications and maybe referral to a nutritionist to help with some weight management will be beneficial in our patient population. You'll also want to monitor for iron overload at least yearly. You will check or monitor for heart failure. You'll screen with an EKG after transplant and yearly. A lot of patients will receive routine echocardiograms post-transplant, and then of course you want to do anything based upon symptomatology that the patients present with. And screening for coronary artery disease, you really want to just do a yearly clinical assessment, assess for symptoms consistent with angina. Routine EKGs is certainly reasonable, and then anyone who's symptomatic, you definitely want to consider doing stress testing on. Otherwise, in the long-term setting, our biggest recommendation would be prevention. If you are able to minimize the patient's modifiable risk factors. That is the best thing we can do to encourage good cardiovascular outcomes longitudinally. So you definitely want to consider a formal exercise program. There's a newer specialty that's called cardio-oncology rehabilitation that really can improve the patient's cardiorespiratory fitness. The patient's cardiorespiratory fitness is a risk modifier for both cancer and cardiovascular disease, so it's a win-win in our patients' situations. Otherwise, improved exercise capacity directly correlates with overall prognosis in our patients who have underlying cardiovascular disease. So I cannot stress enough, try and get our patients to an exercise program. Otherwise, a dietitian or nutrition consultation to help with weight management and our diet intake. Otherwise, we want to treat comorbid disease states aggressively. So if you identify high blood pressure, high cholesterol, any other comorbid conditions, you want to treat those as aggressively as possible. And again, early identification and prompt treatment is really our mainstay in the long-term setting. So some take-home pointers from our lecture today is that cardiovascular complications of stem cell transplant can be a great source of morbidity and mortality in our patient population. We really want to be as proactive as possible to modify risk factors as able prior to transplantation. We want to treat aggressively if we do find any cardiotoxicities. Again, prevention is key. And routine cardio-oncology screenings should be conducted on all transplant recipients. At this point in time, I just want to say thank you all for having me here today, and we will open up the forum and have Dr. Deloria come back on for any questions, comments, and anything else.
So thank you, Katie. I really appreciate your time and effort. I'm sure it took a long time to gather all the data, and especially providing your personal perspective on how to manage this complicated patient. So we have a question which is around priority nursing care. So can you give a little bit of specifics about patients who are at high risk for getting cardiovascular complications? What factors are important from the nursing perspective and the day-to-day management of these patients? And are there any warning signs which we need to look out for? As far as management of fluid and diuretics and all those things. So if you can give us an overview, please.
Yes, absolutely. Can you guys hear me okay still?
Yes, we can hear you.
Perfect.
Thank you.
My computer has such technical issues, so I do apologize to everyone for that. But in regards to nursing care and management of our patients to prevent cardiac complications, the biggest thing I can recommend is monitoring fluid status. So that is our number one most important thing we need to do. We really need to have strict monitoring of our patients' input and output because volume status is really what drives a lot of our patient complications. If our patients are febrile and having a lot of insatiable losses of fluid, it goes both ways. You know, if a patient is dehydrated, they're at higher risk of atrial fibrillation. And then of course, if our patient is volume overloaded, they're at higher risk of CHF. So really volume status is the most important thing. Some early warning signs and symptoms, obviously, if anyone's complaining of palpitations, chest pain, shortness of breath, if visually you're seeing that they're very edematous, those will be things that you'll want to document and alert your providers of. Otherwise, let's see, manage your electrolytes. So make sure those potassium and magnesium levels are within a good range. Yeah, Boggy, do you have anything else you'd like to add to that?
No, so a few additional things specifically about our cardiac amyloid patients. So we actually do a good number of patients who had prior cardiac involvement with amyloidosis. And when we take this patient through high-dose melphalan-based chemotherapy and autologous transplant, several of them will develop arrhythmias and volume overload, renal dysfunction. So typically among those patients, we do inpatient transplant. So compared to rest of our autos, which are completely outpatients, our cardiac amyloid patients do get admitted for not only transplant, but also stem cell collection, because GCSF at high dose can lead to sometimes fluid retention and arrhythmia. So we do collection and the transplant inpatient for amyloid patient. We do consult our cardiology colleague when they get admitted in the hospital, and they monitor their patients on a telemetry devices on a day-to-day basis. There is also a device you can implant intracardiac. I'm blanking on his name right now, but the cardiologist can put it. Yeah, cardiomim, yes. So that's actually a very wonderful instrument because it can be inserted non-invasively through a left heart cath before you start the transplant process on this patient, and it'll give you a real-time update about their intracardiac pressures and the volume status. So we have used that in a handful of patients who are at high, we think are at high risk of volume-related issues during the stem cell transplantation. The other thing to keep in mind is the people who are at high risk of arrhythmias are patients who receive post-transplant cyclophosphamide and especially our CAR-T recipients. So during the phase of CRS, they have a lot of systemic inflammation. They're being treated with tocilizumab and high-dose dexamethasone. And these patients do, during the first 4 weeks after CAR T-cell infusion, develop, several of them will develop cardiovascular complications. So having a prompt treatment for CRS is a key here to bring down the level of inflammations to protect them from getting the subsequent cardiac complications.
Absolutely. Thank you.
The second question we have from our participant is there any benefit of using cardioprotective medications during the transplantations to prevent the late complications? So I would say something like beta blockers or statins. What's your take on this?
Yeah, so my take on that is anyone who you've identified has risk factors. So anyone who does have CHF that you've diagnosed or cardiomyopathy that you've diagnosed from an echocardiogram, you definitely would love to have them on a beta blocker if their blood pressure can tolerate it. Obviously, our cardiac amyloid patients don't tolerate beta blockade very well, but for everyone else, certainly if we can do disease modifiable medications, we should. The only caveat I'd say is obviously ACE inhibitors are a highly recommended medication, but with our use of tacrolimus, it is always, it can be challenging to use them with the AKI and the hyperkalemia that can occur. But if you identify any risk factors, or certainly if you have any documented cardiomyopathy or coronary artery disease, you definitely want on disease modifying medications preventatively.
Yeah, and just to add to what you just said, I agree, of course, Katie. There is little evidence based on prospective data of doing primary prevention medications, such as just people who had no history of cardiovascular risk factors and putting those individuals on just statins or beta blockers. So at least at our programs, we are not doing that. But unless, like Katie says, somebody had prior cardiovascular risk factors, we do tend to start them on these cardioprotective medications if they otherwise meet the criteria for this medication, not just for the sake of prevention because they are going through the stem cell transplantation. And regarding the hypertension management, especially early post-transplant, people who are on calcium inhibitor, the calcium channel blockers are your friend. So we tend to use them heavily, Norvasc and nifedipine. They tend to be quite safer on the kidneys and had a quite a decent response to the blood pressure, especially when having issues because of calcium inhibitors with a less impact on the renal function. However, it comes at a cost of having lower extremity edema, which we tend to manage with diuretics.
Absolutely agreed.
Yeah, don't think we have any questions from the audience right now, but let me ask you regarding like a late complication. So our transplant survivors, especially individual 2-3 years from an allogeneic stem cell transplant, of course, there is a less concern about the relapse of their primary malignancy at this point. But I tend to see these patients in the long-term survivorship clinic. So what are the issues in those cases? We need to monitor them, and how often you check their lipid profile, or do you repeat an echocardiogram on those patients? And so what are the suggestions for long-term survivors of this transplant?
Yeah, thank you for that question. Certainly for our long-term survivors, they are at very high risk of developing the cardiovascular disease, which is the whole point of this talk today. Our patients, we definitely need to be checking their lipid panels at a minimum annually. Certainly, if you see any trends towards elevated lipid panels, maybe not to the point where you're requiring medication just yet, you'd want to certainly increase your frequency of screening. Certainly there's utilization and screening up to every 3 months while you're trying to initiate dietary modifications and an exercise regimen. In regards to screening for cardiomyopathy, I'll be honest, I might defer this back to you, Dr. Deloria. Certainly we go symptom-based. Obviously, if anyone's having any unexplained shortness of breath, bilateral lower extremity edema, you'll definitely want to be doing an echocardiogram. But just routine screening echocardiograms, is that something that you often try to do annually or just based on symptoms?
So I think it answer really depends on their pre-transplant cardiovascular risk profile. So especially now we don't see that anymore, but young Hodgkin's lymphoma survivors who has thoracic radiation, or I have actually several cases, ladies with a prior history of breast radiation for the breast cancer, and then subsequently developed acute leukemia from the chemotherapy they received for breast cancer. And then subsequently we did a stem cell transplant. So in those type of cases where they have anthracycline and thoracic radiation exposure, I do tend to recommend that at least an annual echocardiogram to monitor these patients, because many of these patients will develop late cardiomyopathy, and largely they're asymptomatic until they develop advanced heart failure. But no, I do not generally recommend for somebody who's otherwise healthy and with a minimal cardiovascular risk factors to do just routine echocardiogram on an annual basis. Let's see. Okay, I think that was a question from Arifa, which I just answered. So thank you. Yeah, I think especially for pediatric patients or AYA patients who is going to live for many, many decades after an allogeneic or autologous stem cell transplant, those patients, it's worth getting them closely monitored and their lipid profile checks, their diabetes checked, at least an A1C monitoring, and echocardiogram based on their prior history. Let's see, I don't think we have any more questions here from the panel. I think this is it. So I would really want to thank you for your hard work and summarizing all the literature for us and our audience. For the audience, please feel free to email or tweet at us if you have any questions or concern, and if you have any difficult case, we'd love to help out whichever way possible. So thank you so much. And this will be archived in IACH website for future review. Thank you.
Yes, thank you all so much for having me. It was such a pleasure. And again, apologies for all my technical speaker and sound issues. It's been a true pleasure. Thank you.